Okay,
Welcome to tonight's Woo You event.
it's all my fault. I
For
totally
those who came in a
apologize.
few minutes late, here we are.
I,
I'm your host, Dr. Jennifer Stewart, who is not a Mac person, so I couldn't help it all. Thank you to Metro Optics for exhibiting at tonight's event. For each hour of CE, attendees must be online for a minimum of 50 minutes. For a COPE certificate, please fill out the survey link in the chat. The survey link will also appear when the webinar ends. CE certificates will be delivered by email and sent to ARVO with your OE tracker numbers. We'll also display a QR code at the end of the event if you have the OE tracker app on your phone. CE certificates will be emailed within 4 weeks, and make sure to ask questions using the chat or Q&A. Here's where you can find it on your phone. And it is my great pleasure to introduce Dr. Tom Arnold. He's a graduate of the University of Houston College of Optometry. During his training, he participated in vision outreach programs in Mexico, Guatemala, and with the Bureau of the Indian Health Service. He spent 2 years as a research assistant for the Early Treatment Diabetic Retinopathy Study at the University of Texas Medical School in Houston. He's passionate about scleral contact lenses and their ability to help patients struggling with compromised vision related to the cornea. He's a fellow of the Scleral Lens Education Society and an associate member of the International Society of Contact Lens Specialists. Dr. Arnold, along with Dr. Melissa Barnett, are formerly co-chairs of the International Congress of Scleral Contacts, the first meeting in the world dedicated solely to scleral contact lenses. An international speaker, he has presented in Russia, Poland, India, Jordan, South Africa, Colombia, Mexico, Italy, the UK, Australia, Israel, and at major meetings in the US. And woo you. Welcome, Dr. Arnold. I'm going to turn it over to you, and I will see you at the end.
well, thank you very much. I apologize for all the snafu at first. You can tell that I am retired, so I guess I'm out of practice. So my apologies and thank you all for your patience. It's a pleasure to be here. I've been friends with Dr. Stephanie Wu for many years. When I first started this scleral lens journey, she taught me a lot. We spoke together. We even wrote some papers together. So it's an honor and a pleasure to be here at Wu U. And the subject tonight is scleral lens fitting. And the sclera is a different animal than the cornea, where we're used to putting lenses on and looking at corneal shape and curvature and K values and these kind of things. The sclera is a different environment. And that is what we're attempting to fit when we consider a scleral lens. We're going to talk about how the scleral shape is different than the corneal shape and how manufacturers have uh, strived to make more sophisticated lenses for this. 10 years ago, 20 years ago, when I started, most all of your scleral lenses had spherical back surfaces, but not much was known at that time about what scleral shape involved. And most fitting sets, certainly my early fitting sets, did not have toricity in the landing zone as even an option. And we'll talk about kind of why that is. A very early study that really brought to light how the scleral shape, the scleral surface is different than the corneas, was this study out of Pacific University by Pat Caroline and his team. And what they did is they took a Visante OCT made by Zeiss, and unfortunately it's no longer available. This is one of the first OCTs that you could actually look at the entire cornea, nasally, temporally, and superiorly, inferiorly. And what they did is they looked at the angles over the limbus and onto the sclera and recorded those values. And they first took angles. They measured two angles uh, from 10 to 15 degrees core diameter, and then out to 20 degrees. And you can see here that uh, at 15, the scleral angle was about 39.4 degrees. When you get out to 20 millimeters of chord length, or all 20 millimeters out, then that angle is 42. So that's three degrees different, which is quite significant. And this was significant in all the different meridians, as you can see here around the clock. Now, when you're at 10 to 15 millimeters, the difference is not that significant. And I'll point your attention to the photo where they have the little green bar. So these values span the limbus onto the start of the sclera, and that's important, and we'll see why in the next couple of slides. And you can see here from 10 to 15 millimeters, the angles are not all that different in the major meridians. However, when you go out to 20 millimeters, the situation changes. And you can see in this slide that at 20 millimeters, it's already 42 degrees of angle. And when you compare, when you look at these values, look at the difference, say at the 2 o'clock position where the angle is 36 degrees, which is on the nasal side, and right across at 10, the 10 o'clock position, you can see it's 42 degrees. So that's 6 degrees of angle difference, across those meridians. And again, looking at the photograph, the little red bar indicates the angle where they're measuring. And this is the other point about this is these values are straight, they're linear. So the first thing to remember about the sclera is that it's straight. It's no longer curving like the cornea is, like we're used to seeing the cornea. And we put the data together, then look at the difference at 12 o'clock. You have 3 degrees difference from 15 to 20 millimeters, 15 millimeters out to 20 millimeters. If you look, compare nasally, temporally, look on the nasal side at 20 millimeters out, it's 36 degrees. On the temporal side, it's 41. So that's 5 degrees of difference. So quite a bit when we go from 15 to 20 millimeters, which is where we're fitting most of our scleral lenses these days. And the interesting thing about this slide, again, from these data, is that when you look at the angles over the limbus, they do change in all the major meridians, starting over the limbus. And when you get out to the sclera from 15 millimeters out to 20 millimeters out, you see a great difference in all the major meridians. And this is what makes scleral lens fitting sometimes a challenge. So why is that? Well, I'm sure everybody here remembers their ocular anatomy and they remember the spiral of Talot. And what he described was that if the distances from the limbus to the extraocular muscles changes in a spiral, with around the clock shape, starting with the medial rectus, superior or inferior, temporal, and then superior. You can see that as you go around the clock, the distances of the insertion from the muscle to the cornea itself really varies. And not only that, not only are the distances different, the angles are different, which is what we've just been looking at. And further, the elevation of these structures is different. So this is why lenses tend to decenter down and out, because you get more angles, more regularity as you go inferior temporally. Now, a really excellent landmark study was done in 2017 by Greg Denier and his colleagues. And this was published in the Journal of Contact Lenses. And what he found, they examined 140 scleral lens patients. And they were measuring the sclera, the shape of the sclera, using profilometry. And what they found was after these 140 patients, only 6% had what they called a spherical scleral shape. And their definition of spherical, interestingly enough, was that there was no more than 300 microns difference between the major meridians, superior, inferiorly, and all that. So we consider that 300 microns of toricity in the sclera surrounding the cornea is what we call spherical, right? Very, very low number. Toric regular, 28.6%. What that means is that it's with the rule or against the rule. It's steeper vertically and flatter horizontally, or vice versa. But still, we only account for a third of our patients in these two categories. When we look at the majority of the patients, 65.7%, almost 2/3, They are asymmetrical. They either have asymmetrical high and low points, which we're going to discuss in just a second, or they have no regularity at all, what we call periodicity different from 180 degrees. So your steeper meridians may be superior nasal and flatter, temporal inferiorly. So there's no pattern. And I would urge you all to read this article. It's from Journal of Contact Lens and Research in Science, and a land-breaking periodical, in my opinion. Really, really good. Now, these are the same data, just in this pie chart form, and it just really brings it out to me that the majority of your patients are going to have toricity. They do have toricity, and we're lucky if it's just regular, steeper vertically and flatter horizontally, or vice versa. A lot of them are asymmetric, and some of them are 25%, 1 out of 4 are going to be highly irregular. And this is true when you get the more ectatic cases in your chair. This is a little map from that study from Greg Denier, and he's just showing this is what asymmetry in the same meridian describes, what they're talking about. And in this case, we're looking at an elevation map of the sclera. In elevation maps, and we'll talk a little bit more about this in detail later, in elevation maps, the blue is steeper than the best fit sphere. So it's the steeper area. And you can see that's vertical. So we would say this is a with the rule scleral shape. But the difference in that same meridian at 12 o'clock to 6 o'clock is 200 microns. So the significance of that is that, let's say you identify, well, it's, sclera is steeper vertically. Let's put some toricity in the haptic, but you're still going to be 200 microns off in that same meridian. So it just talks about the complexity, or brings out the complexity of fitting these shapes. And that's why you'll see us going more to quadrant specific shapes to attack these positions. So very, very good. Again, on elevation maps, blue is steeper because it's below the best fit sphere, and green or yellow or red is higher than the best fit sphere. It's different than your axial and tangential maps. So again, these data show that scleral toricity actually starts at the limbus. Good friends of ours, Dottie Fidel, has done a lot of study on this. We'll talk about her paper in a minute. And then Christine Sant, who's the developer of the iPrint system with molding, has identified that the limbus is often oval and it's a paraboloid. Okay, so we say it's like a Pringles potato chip. It's hyperbolic paraboloid, so it's like a saddle, so to speak. The image on the left is one of my patients, where we did a mold on, and you can see that in the vertical meridian, it's almost a millimeter shorter than the horizontal meridian. So this is the shape of the cornea, and that extends over and affects the scleral shape as well. Okay, and also what we find is that in the shorter meridian, the shorter chord length, and it could be anywhere, it could be with the rule, against the rule, it could be oblique. But the shorter meridian is also going to be higher up. Okay, again, think of the Pringles potato chip. So it's not only shorter one meridian, it's more elevated in that meridian. So if you look at these pictures from Chris Sant, this is why you can have perfect clearance and landing over one meridian, say 3 and 9, as in this picture, but you overshoot the north-south, the 12 and 6 o'clock, because that chord length is shorter. And so you're overvaulting that. And that can lead to various things like conjunctival prolapse and so forth, where you're sucking that excess clearance is creating sort of a vacuum, if you will. And it's going to suck that conjunctiva up into there. So, it's a very frustrating kind of position to be in there. I mentioned Dottie Fidel did some studies on this, and this is from one of her papers from several years ago, actually, where she had measured and described not only the horizontal visible iris diameter, or the HVID, but she said we also ought to take a look at the vertical visible iris diameter because it's often different, as we just saw. And she said, well, in order to address this, there's a couple things you can do. We can make the optical zone oval, over the limbal area. And if we do that, then if we want to keep all the peripheral curves, the intermediate curves, the limbal curves, the landing curves, if we want to keep them all the same width, then you're going to have an oval lens. And I've actually made some oval lenses for people that had a lot of exposure, temporally at the outer canthus, had a lot of exposure there. So sometimes a oval lens actually is quite a good thing to do. The other thing you can do, and a number of manufacturers are starting to do this, they'll make an oval bowl, if you will. The first, primary curve can be oval in shape with different meridians, different sagittal heights in each meridian, vertical, horizontal, or vice versa. But then, in order to make a lens that's spherical on the outer edge, which is more common, you vary the width of your peripheral curves in order to accommodate a spherical, outer curve. And so either way, it gets the job done. But it's interesting, and this paper is several years old, so this is something that's been known for some time, and you might, whichever lab you're using, you might ask them about this feature. Okay. Now, Greg Denier's team didn't stop there. Several years later, in the same periodical, they had another slide or another article where they took, over 300 patients who were wearing scleral lenses, and they divided them into, the group A and the group B. And the group A people, the prolate corneas may have keratoconus, may have had steeper corneas, but they were more regular in shape. And then you had the more ectatic corneas, which they put into group B. And so the group B, of course, as you would expect, had significantly more irregular shape versus group A. So again, the corneal shape predicted what the scleral shape's going to be. And the bullet point, or the pearl out of this paper, which is very, very good to keep in mind, is that when the apex of the cornea was more than 1.25 millimeters away from the center of the cornea, then their scleral shape was going to be much more ectatic and much more what we call quadrant specific. So they're going to have a different sagittal height, certainly along one meridian and maybe even adjacent meridians. So again, you may be thinking about lenses certainly with more toricity than you would normally recommend or think about, or even a quadrant landing zone. So very, very good paper. I recommend these papers to everyone. So toric landing zones, yes, of course. Okay. When you order a toric landing zone in a lens, be bold. Do at least 120 to 180 microns difference. Because as we said, spherical is anything less than 300. So you won't go wrong with that. And as we've seen, many, many scleras are in this range up to 300 and more. Yeah, I would say even more. Okay. Larger lenses, 15-2 and larger, certainly are more likely to require a toric PC. And 15.2 is still a fairly small lens. I think a lot of people are fitting in the 15/8s and into the 16s, 17s, and even the 18s. I think as we become more familiar with scleral lenses, we tend to go a little larger. And of course, keep in mind the original sclerals were quite large. They were 21 to 24 millimeters. But I think most of us in most labs were fitting lenses between 15 and 17 millimeters. But even then, you should consider toricity in the landing zone. Some labs, again, provide fitting sets with toricity built into the landing zone. So you're a lot closer to your endpoint in your diagnostic set, which I think is very helpful. And I think many practitioners, this is just personal comments from people I know, have toric PCs, 80 to 95% of the time. Some people, do it all the time, but certainly something to consider. This is just a tip. Here's a fitting pearl for you that I learned several years ago from a good friend of mine, Hector Velasquez from Venezuela. And he said, yeah, if you take some lissamine green, which is a great, vital dye, and you dab it onto the bulbar conjunctiva, any areas where you're not tangent, your landing zone's not tangent to the sclera, the lissamine will go right in. And lissamine's a very um, light molecule, apparently, not viscous at all. Just use a saline drop to wet it, and it goes right in. It'll show you exactly where your leakage is coming from. This is especially good too when you have midday fogging and you're wondering where all this debris is coming from. Listening green will show you immediately, and you view this in white light, and so that's a very good pearl I'd recommend to you. All right, so a lot of these people, and we have several examples coming up. A lot of your typical patients will have very very significant amounts of myopia, astigmatism, very irregular astigmatism, maybe. Um, and so the tendency that you'll oftentimes need to put RX into their prescription in their scleral lens. And we have several cases that we'll review in a minute where that is indeed the case. But when the amount of cylinder is fairly small, I'm going to say less than 2 diopters, I would urge you to order your first lens as a spherical lens. Now we're talking about RX. We're talking about the actual prescription. We're not talking about landing zones at this point. I would order the spherical equivalent in many cases because we talked about how lenses are going to decenter on you. And when they decenter, they'll decenter. That can cause some induced cylinder. And also, they'll rotate. They're going to have more rotation. And so if you look at the picture in the middle here, you can see a significant, decentration and a prismatic effect from that decentration. And in the picture on the right, you can see that the difference in a well-aligned lens with using fluorescein here compared to a lens that's decentering, and it's very easy to see this prismatic effect with fluorescein. So my preference, if I can get away with it, is to order a spherical lens, at first, and get it centered and get it fit well. Because when you do that and you get it stable, then you know that if you need to add cylinder, it's going to be in the right place and be where you want it to be. There are exceptions, and we have a couple coming up that we'll review, but that's just something I'd like to pass along. Okay. All right, so let's talk about a case. This was one of my very early fits when I started fitting scleral lenses, because I was in practice about 15 years before I started fitting scleral lenses, before they became popular kind of in the early 2000s. And this was a patient of mine that I'd seen for a number of years who had keratoconus. In the days when I started, we had cone lenses. We were fitting people with very small PMMA lenses in many cases. And I'd fit him in a variety of lenses. And he had some diabetes, type 2 diabetes. He had cholesterol. He was an engineer, he was an outdoorsman. So this was important to him to be able to participate in sports and hunting and so forth. And so, scleral lenses would be an ideal thing for him. His daughter also, had keratoconus, and I had fit him, as I said, in a variety of lenses. And then he was game for a scleral lens, and you can see that he did have significant refractive cylinder in oblique meridians, but he was correctable to 20/20, and this guy was really easy to work with, a really nice guy. And so when we look at his maps, we see, a very advanced case of keratoconus. The axial map is on the left, the elevation map is on the right. And going back, kind of emphasizing what I talked about a few minutes ago with the profilometry, axial maps, tangential maps are power maps. Okay, they tell you where the power change in the cornea is coming from. They are not the shape of the eye. That's very, very important. You know, I'm sure most of us have a little model in our office, maybe some sort of cone type thing, and we describe keratoconus to our patients as a cone shaped cornea. And we think of the cornea as like a missile coming out. And the axial map here, kind of reinforces that. So, well, look at this big red dot. You know, this is your cone coming out. But that's not the case, right? That's the power change that occurs because of the shape of the cornea. So the elevation map tells you the shape, right? And so when you see the big red dot on the axial map, that comes out blue on an elevation map because it's that the change in curvature, that inferior cone changing the curvature is dropping away. Another reason why lenses tend to decenter. Most cones, common oval cone is down and out. And so that's where you're seeing here. Okay. So the elevation map's telling you the shape of the cornea. Okay. I did a lecture for Wu University called Battling Astigmatism. I think that was last fall. And I did a deep dive in all of these different maps and analyzing them. So if you didn't catch that, I would very much recommend that Wu U presentation, Battling Astigmatism. And in my early days of fitting, I fit lenses that were fairly small by today's standards. And this gentleman had a small HVID anyway. So this is only a 14.9 overall diameter lens. It's oblate. Oblate meaning it's got a flatter base curve than peripheral curves. That induces a minus tear lens, if you will. So even though he was very highly myopic with an oblate lens, you could you get a lot of power from the flattening of that curve. So his final RX was only plus 75 one diopter of cylinder at an oblique axis. So again, I was able to put cylinder in this, but only because I stabilized it. And I stabilized this lens, one, because it was smaller, so we didn't get into the real ectatic zone that we saw in the sclera as you get out away from the limbus, but also because I put extra limbal clearance in the limbal curve. That's what the XCL stands for. And then it was toric, like the Dottie Fidel paper that I mentioned earlier. We put an oval, limbal curve in there, and that helps stabilize it as well. His landing zone actually was the landing zone, or the haptic zone was actually spherical. And we were able to do that because this was a very small lens. But he was very happy with it. It was very stable. He could wear it for many hours, and he did really, really well. So you can stabilize a lens, especially if you need to put cylinder in the RX, by using a toric landing zone, as we talked about, or maybe even a quadrispecific. Another trick, and I practice in Texas, Houston, Texas, and very, very hot, a lot of sunshine. So we had a lot of pinguecula that we had to deal with. And you can use, notching or, peripheral microvolts, if you will, to get around these bumps. And it's really kind of a good tool because the lens kind of grabs that zone, and that'll help kind of anchor the lens as well. So don't avoid, if you see pinguecula nasally or temporally, go ahead and address that by going around them if you can. And of course, your lab can help you do that sometime, from time to time, and that'll stabilize the lens. So that's what it's all about. Our goal is to get a really nice, well-centered lens. And this is a different patient, but you can see here that the lens is landing gently. There's no impingement on the blood vessels. You don't see any blanching here. The blood vessels look like they just go underneath uninterrupted here. So this is what you want to strive for. Okay, just another case. This was a patient of mine that 39 years old. He was diagnosed with keratoconus. He was a salesman. He came to me from Beaumont, Texas, and I was out of Houston. So it's about 120 miles away. But he was referred to me. He was wearing soft contacts, and he just said, "I've never seen well. Yeah, I never have." And you can see from my photograph here, he really had kind of that big oval cone that's so typical. Here's our axial maps again. Now this is looking at the cornea, and you can see that he's got a very steep cornea. His prescription is extremely high. Look at all that cylinder oblique. So this is a fairly typical patient that you will see. So looking at the axial maps, yeah, this is significant keratoconus. But let's look at the elevation map. I had a pentacam, and so you can look at with a tomography, we can see the front elevation and the posterior elevation. You can see that his Kmax in his right eye was almost 80 diopters, which is quite a bit. He was very thin cornea, although I've seen thinner, but still it's fairly significant. But the point here about keratoconus is that it's often starts and is more pronounced on the posterior surface. You get more ectasia on the posterior surface, and this can affect the final outcome and the visual outcome. So what I mean by this is that when the ectasias line up, okay, when the elevations of the front and the back are in line, then your chances for good functional vision is greatly improved. And you can be pretty optimistic and positive with your patients that scleral lenses are going to help them see better. So again, front elevation compared to rear elevation, where do they line up? And if they do, then that's a good sign. And most are like this, especially in early or moderate keratoconus. And now, we have cross-linking. So I hope that you're screening early. And when you identify these patients, send them for cross-linking. Don't let them progress. Try to keep them out of the more dangerous stuff. And this is what you see here. This is a different patient. And so when you can see this is severely ectatic, and you can see that there's no regularity, particularly on the posterior surface. And so, you want to be very guarded in your prognosis. Scleral lenses fit well, they're comfortable, but um, they may not provide as sharp a vision as maybe a corneal type lens might. Again, the shine fluid just showing you this very ectatic cornea. Okay, so going back to this gentleman from Beaumont, we had fit him in 2019, and he had been doing well. He was comfortably liked it. And he came back for an annual visit, and he said that left lens was bothering him a little bit. Um, this is my little sketch of what I saw in the slit lamp, and that you can see that I thought that the left lens was decentering a bit. It had, it slipped a little bit. He had 200 microns of toricity in the landing zone, which is not that much as we've seen. It's almost spherical. So I thought, well, the best thing to do to help center this lens would be to increase that. Karen Carrasquillo, a good friend of mine from Boston, says that you should always finish an exam for scleral lenses by removing the lens, staining the cornea, and looking at it. And Chris Sent emphasizes this too. We're treating a disease process. We get concerned and caught up with looking at the lens and the lens and the lens. We're treating the eye, so we need to look at the eye. So by removing the lens and staining, we can see where he's being abraded there and where he's actually getting some impingement. So what did we do? We went to 275 microns of toricity, 16 millimeter lens. So this is very appropriate. And I would say even now, even today, I would probably be going more like 350 or 400. Um, Toricity is a very good thing to do in these landing zones. They really solve a lot of problems. You can see his eyes nice and white and very, very clear. And we had this good, even plano uh, post lens reservoir, fluid reservoir picture here of the sclera. So I was really glad we were able to do that. And you can see here, very, very white now and well centered and everything. So that was a good case. Uh, just a note here, just want to throw this in. Depending on what lab you use, and there's many, many good labs in the United States, and thank you to Metro Optics, who is one of those excellent labs in supporting our talk tonight. Every lab, when they design the lenses, they have their own little terms for the haptic or the landing zone or flat or steep or whatever, or sometimes in degrees. So there's this paper was an attempt by Langis Machad and others to kind of codify everything. So we're all using the same terms. It's a very, very good thing. I don't think we're there yet, but I think we're moving in that direction where everybody's kind of using the same terminology. Okay, and this is something from Dr. Wu. Uh, Her patient, an ophthalmologist that she worked with, referred this patient to her. RK, scarring, epithelial ingrowth, double vision, fluctuating vision, a lot of complaints. And I will say from my personal experience in my practice out of Houston, we had lots and lots of RK. Houston, has a very big medical community, and they were very aggressive with the radiokeratotomy and throughout the 70s and even into the 80s. And so I fit a lot of people that were post-RK ectasias. And honestly, I'd rather fit a cone or a graft than the RKs. They're very, very difficult change. They're very, very difficult cases because their cornea is, oblate now and very irregular. So this was the case with Dr. Wu's patient, very, very typical. You can see from her maps, they were very, 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 very irregular. Okay. So she had scarring from the RK, which is very typical. She had some sutures there, which you can see in the photograph. She also had a cataract, but fortunately she had good, retinal health. So it was a normal eye otherwise, just unfortunately not the RK result that she had wanted. All right, so Dr. Wu reached into her fitting set, got a 16 overall diameter lens, which again is very, very typical, and with a spherical cylindrical over-refraction, she got 20/30 vision with some cylinder there. Clearance is 400, which is great at the initial fitting with the 16 millimeter lens. That's a really good clearance to start off with. Her left eye, same thing with even more cylinder. She got 20/30. So she decided that that was enough cylinder to go after in the first lens, and that is what she ordered. So the patient really responded well to this, was very, very excited. Um, she did have a lot of astigmatism, and so she went with a toric lens. And so this was her lens dispense, and you can see from the photographs there, it's centered very well, it aligned very well. We don't see any blanching or impingement. The dot just indicates it's a right lens. And Dr. Wu has this great OCT that took all these different angles from all these different sides. 238 microns is great. It's going to get a lot of good oxygen at that amount of clearance. And that was her dispense. So that was really super. This is her left lens, 2 dots showing the left lens. Little bubble there that you can see in the third slide. And that probably is just an insertion bubble. You got to be careful to overfill the lens, put it on tangentially, don't jam it up in there to avoid bubbles. And here's her OCT from the left eye, 209 microns, which is really, really good. So this was a very, very successful fit. And she dispensed the lens, and she had 20/20 vision, 20/20. So she was a very happy lady. So she was thrilled with her vision. She 2-week follow-up, no changes. 3-month follow-up, still doing well. Uh, this slide reminds me of something that also I think is very important, and that is you see here that Dr. Wu dispensed the lens and said, "Come back in 2 weeks." I think that's a really good time frame for the first follow-up exam. What I mean by that is you want them to wear the lens out in their everyday life, driving, reading, working, studying, playing sports, uh, because so many things are going to happen those first 2 weeks. I think it's sometimes practitioners make two different mistakes. They make a mistake where the diagnostic lens, they don't like the fit. They think something's wrong with it, although it's functional. Let's say the patient can see, but the doctor says, well, it decenters too much, or I want more clearance, or whatever. And they don't even dispense the lens. They just order another lens. I think that's one mistake. Second mistake is dispensing the lens, but having them come back in 3 days, or 5 days even, or even a week. And the reason I say, in my opinion, that that's a mistake is that they haven't given the lenses time to settle. Okay, lenses will sink into the conjunctiva over time. They will rotate. This is why I don't like to put a lot of cylinder in the lens if I don't have to. I'd rather dispense a spherical lens if I can, and if I have the ability to cut and edge a lens in my office, which I did, I'd make up some cylinder in an inexpensive pair of glasses, single vision lens, put the cylinder in that, have them wear the glasses over it. Because the lens is gonna sink, it's gonna change its clearance over the cornea, it's gonna rotate, some degree, and you may decide that you want to change your overall diameter based on that. Not even even more than the haptic. So if you give it enough time, at least 2 weeks or 3 weeks even, uh, all those things you can do at once. The settling will be obvious, the rotation will be obvious, the over refraction will be more stable. And then they'll have various experiences that they can talk about, challenges with insertions or removals or whatever they have. So give them time, give them time, give them a nice pat on the back, give them a lot of confidence. Your staff needs to emphasize, how exciting they are, how excited they are for the patient, and how well they're going to do. So a little positive reinforcement goes a long way. And before I leave tonight, I do want to say something about rigid gas permeable lenses. Okay. Uh, Again, back in the day, the old fogey day, that's all we had was corneal lenses, and we fit many um, people. If you wanted contact lenses, they were corneal lenses. Uh, and they certainly have a place. Okay, now that we have good topographers, we can fit empirically. The labs are very good at taking the prescription and taking the refractive data and the topography data and making a pair of lenses that are very close the first time. I mentioned Metro Labs, our sponsor tonight. I've worked with them personally over many years, and they are excellent at this. They're excellent at Scleral lenses, but they're also very excellent at rigid gas permeable lenses. Um, I have some notable practitioners, friends of mine, who prefer a corneal lens if they can get away with it over penetrating keratoplasty, concerns about oxygen deprivation and so forth. Now, and I will say in these days, patients may be resistant to a rigid lens. They're habituated to a soft lens, thinking soft lenses, or they may, be referred to you for a scleral lens fit, but that's not necessarily the best thing for them. And so my good friend Gary Gerber, who started the power practice, said has this little motto here, which I think is excellent. He talks about the 4 R's, and the 4 R's are repeat, review, recommend, and recall. Repeat means you repeat back to the patient all their problems. They can't drive at night, their eyes in pain, they can't see, whatever it is, what they want to do. You review your findings, you review the topography, review the refraction, you look at the photographs, and you review that with them. And then you recommend, you say, based on my experience of your case, I think this is what we need to do. We need to do. It's a cooperative enterprise, you and the patient. And then you recall them, of course. So I would urge you to think about RGPs, and to back that up. Again, research out of the Pacific University, who did the scleral mapping that we started this presentation with, Randy Kojima and Pat Caroline, measured corneal elevation differences, and we're talking about the cornea now, in the meridian of greatest curvature. And if that elevation difference was less than 350 microns, corneal lenses may be considered and may be preferred. Subsequent studies in 2033 confirmed this. Again, they did more studies. So elevation differences between 200 and 400 microns could go either way. Randy Kojima, if you don't know him, is a certified fitter, has many different fellowships. And his topography series on YouTube is very good. Randy's truly an expert on topography and a great lecturer. So I would recommend. And I think he's appeared here at WU before. So talking about his study, just to sum up, what he was doing, he was finding the meridian with the most elevation difference. And if we look at the maps on the upper left, where we're beating the horse that I've been beating all night, is that axial maps or power maps, elevation maps describe the shape of the cornea. So we're really looking at the elevation maps. So they found the meridian where there was the greatest change over an 8 millimeter chord. And what they found was, if that elevation difference was less than 350 microns, they were very successful in an 88% success rate of fitting a corneal lens. Okay. Because there wasn't that much elevation difference. They could take a lens and fit it, probably using maybe a bitoric design, and fit it successfully when the elevation difference was less than 350. Now, obviously, when you get over 350, you have a much more attic thing, and then then you're into the scleral lens territory. But this is something to keep in mind, because even though you have adaptation challenges maybe with a corneal lens, you certainly avoid all the scleral stuff we've been talking about tonight, all the irregularities. So don't abandon your RGP lenses. They're easier to get, they're less expensive, they're easier to maintain. You just have a little adjustment to them. So I would again recommend that to you. And with that, I'm almost out of time, and I'm happy to discuss this with anyone. This is my email. I have a website. And for those of you who really want to expand your knowledge and get some help on these difficult cases, I would urge you to join our Scleral Lens Practitioners Facebook page. We run, Nate Schramm and Melissa Barnett and I run this on Facebook. We don't allow patients. Okay, we're not giving patient advice. It's just for practitioners and scleral lens fitters, and anybody involved in that. We ask some challenge questions, so answer the questions just so that we know who you are. And we certainly like to see you there. And with that, I'm going to turn it over to Dr. Stewart. He's going to talk about the next presentation. Again, my apologies for starting off and being so discombobulated at the first. So thank you all for staying with me. Thank you all for spending this time with me, and thanks to Dr. Wu for inviting me to Scleral Lens